maybe some specifics on a topic, or just general to know kind of what the ASMBS is all about and what kind of presentations that we offer. So we've picked some of our top sessions today. And what our goal is to give you brief snippets of a few of these presentations today, and then give a little bit of time for talk and collaboration and questions at the end. So we have 3 great speakers today. We did have one that unfortunately wasn't able to attend today. So we'll have 3 speakers today, along with presentations and comments. So a couple things as we start today, wanted to remind you of a couple upcoming events. If you were unable to attend the ASMBS conference in June, we do have the ASMBS weekend coming up, and that's October 5th through 7th. So that's something that's on the agenda now. If you look online, you'll see the different speakers and presentations that are going to be great, and really the agenda looks like a lot of fun. So take a look at that and see if you can join us. Another thing coming up in September, to be determined on the date, we are going to have a networking event. Part of the best things about ASMBS is networking with others. Actually, Erin and I, one of the speakers, just realized that we went to college together. So, you meet a lot of people and you can really connect. So we have a networking event coming up in September. So watch your calendars for that date, to be determined. So our first speaker today is Kelly Broadwater, and she's going to talk about patient and clinical perspective of disordered eating and eating disorders. So let me tell you a little bit about Kelly. If you didn't hear her at ASMBS, now's your chance. And I think these recaps are great as well, because sometimes there's so many great sessions you want to hear and you can't hit all of them. So Kelly is a psychologist and a certified eating disorder specialist, and her clinical practice includes pre-op, evals, individual counseling, and supervising other psychologists. She's passionate about aftercare programming and is an expert in post-op addictions and eating disorders, and she frequently presents on these topics. She has published professional journals of addictive behaviors and has written for the OAC's Your Weight Matters magazine, which is a great resource for our patients. She is an integrated health associate member of the ASMBS, an approved supervisor with the International Association of Eating Disorders. She recently co-authored a book, Very Educated, which you guys want to check out, a really great resource, an integrated health guide for dietitians and behavioral health specialists caring for the bariatric surgery patients. So it emphasizes the treatments of eating disorders on the MBS population. So everybody needs to check that book out as well. So I'm going to let Kelly take it away. And again, if you wanted to put a question in the chat, I'll jot that down and we can cover those in the end. So thank you so much, Kelly.
All right, is my screen? Here we go. Woo, gotta get technology right. So thank you so much for asking me to be here on the recap. I am providing the clinical perspectives of disordered eatings and eating disorders. We did have a client speak at ASMBS, but she's not here today. So I'll just be talking about it from my point of view. I was very overwhelmed by the reaction to our talk. And, it really was exciting to see how much people needed to hear this information. So I'm glad to share it again. All right, how do I advance my slides? Okay, there we go. The only disclosure, I co-authored the book. So why is this an important topic? One thing to impress upon you, not to scare you, but to just really kind of keep it top of mind, is that eating disorders have the highest mortality rate of any mental health diagnosis. So eating disorders are also incredibly common in bariatric patients pre and post-operatively, which is why I'm talking today. And as bariatric professionals, we're rarely trained in eating disorders and vice versa. So I'm kind of unique in that I've had my foot in both worlds for the past 20 years. And so really hoping to bridge that gap. I think that I know that eating disorders are minimized, underreported, and often go untreated in this population. I think there's a lot of contributing factors to that, weight bias being a major one, and then also kind of the secrecy and shame that goes along with eating disorders. That it's not something that necessarily patients are really willing to share. And so the more we can be able to assess it and treat it, the better, because if it's untreated, it sets clients up for major complications. I've seen some pretty severe cases with some medical issues in a post-operative patient with an eating disorder. So preoperatively, I'm not going to spend a ton of time on that. But really, some considerations. We need to be thoroughly assessing disordered eating. So looking at all different types of behavior, eating disordered behaviors that a patient might be engaging in, and then how often it's happening, how intense it's happening, really kind of sussing out, is this a full-blown disorder? Do we need to get them treatment ahead of time? Which the answer is yes. So the second point might not be the most popular talking point, but treatment to remission really is ideal. This can be discouraging to clients who wanted to have surgery yesterday, and also, might not be something really that surgeons want to hear, that are ready to get people moved through the pipeline and keep their numbers up. But really, you're doing the patient a disservice if they've got an untreated eating disorder and you're kind of pushing them through preoperatively. And then if they have had treatment or they have had a history of an eating disorder, relapse prevention planning is crucial. Relapse prevention is part of recovery. And so really making sure that folks are locked in with support if they have a history of an eating disorder. With both eating disorders and bariatrics, multidisciplinary treatment is the gold standard. So there's going to be a whole team of people that hopefully are collaborating and communicating with each other and supporting the patient. So what does disordered eating behavior look like in the post-op patient? The LABS 3 study really has some statistics that speak to this, and that there's a lot going on. So over 40% reporting loss of control eating, which is, a real feature of binge eating. And somebody might not have a full-blown eating disorder, but loss of control eating is, the most common disordered eating behavior we see. And then binge eating, night eating, and at least one compensatory behavior during the past 6 months. That one was even kind of surprising to me, based on my history of working with clients. So it's definitely going on in our post-op patients. And those are likely, even lower numbers than what's actually happening. There's a wide variety of other eating disorder behaviors. I'm not going to go into each one of these exhaustively because of time, but grazing is one I definitely want to highlight because I see that very commonly in post-op patients. Again, whether they have a full-blown eating disorder, they're engaging in the disordered eating. And so grazing, I kind of call it graze binging, where they eat a little bit here, a little bit there, a little bit here, a little bit there throughout the day, and kind of cumulatively adds up. And they might be eating, kind of non-nutritive foods and things that are not, fueling their body, and, can have some weight recurrence or other issues that come up because of that. So I'm going to go into each of the diagnostic criteria and then some bariatric considerations for them. So anorexia is actually the least common eating disorder we see postoperatively. In my clinical practice of 20 years, I've only ever seen 2 patients that met the weight criteria for anorexia. So it was kind of full blown with all the symptoms and including the super low BMI. So these people are incredibly restrictive and have an incredibly low body weight, an intense fear of gaining weight or becoming fat. It's really to the point of thinking of it as a phobia. And then disturbance in their body shape and weight distortion. So they don't see themselves accurately. And they also don't really, they'll have a lot of denial of the seriousness of their disease state and what's going on with them in terms of their weight and medically. So that's something to keep in mind. Much more common in a bariatric patient is that they're going to meet the criteria for atypical anorexia. So this is where they have all the behaviors and mindset that go along with anorexia, but they don't meet that weight criteria. And sometimes I actually see this inadvertently praised because the patient will say, oh, well, my surgeon told me I was the poster child for bariatric surgery because they've reached a really good weight and they're being very disciplined and very compliant and exercising. But when you kind of go further into it, you have to see kind of what is getting them to that place. So It is not right now in DSM its own diagnostic category. It's under other specified feeding or eating disorder. I think that will change in the future because we're seeing many more cases of atypical anorexia, not just in the bariatric population. But I will say this is something that we really have to pay attention to, labs and nourishment status versus just somebody's weight, which is my first point on the next slide. So really, we don't know what a normal BMI might be for some of these patients. And you have to look at their status of malnutrition. I can think of a client that was in our intensive outpatient program for eating disorders that was a bariatric patient. And she was actually, I think her weight still had her in kind of the obese category. And she would come into my office and complain and say, I don't look like the other women in there. I'm not sick enough. I shouldn't be there. And really what I couldn't tell her because of HIPAA is that her labs were the worst of anyone in that group. I mean, she was definitely the most malnourished. I mean, sometimes she was taking in less than 200 calories a day or less than 20 grams of protein. So again, you can't just look at the weight, you got to look at the labs. And this can be challenging for getting people the right level of care and the right treatment, because if they, if insurance companies are just looking at the weight or a doctor's just looking at the weight, they could very well miss this. So moving on to bulimia, again, a little less common, but we do see it in the bariatric population. This is where someone has recurrent episodes of binge eating with a loss of control. So again, that loss of control being a key factor. And then some type of inappropriate compensatory behavior. So we most commonly think of purging and with bulimia, where somebody's self-inducing vomiting, but there's a lot of other ways people can compensate. So laxatives, diuretics, fasting, and even excessive exercise. And so I think, again, with our bariatric patients, we have to be careful because exercise is something we promote and it's a healthy post-operative behavior. You really have to look at the intensity of it and the intention behind it and determine, like, are they exercising even though they're injured? Are they completely distressed if they can't exercise? So excessive exercise can be tricky to flush out too, especially when this is a behavior that we reinforce in our bariatric patients. It has to be happening regularly to meet the criteria, at least weekly, and it doesn't occur during episodes of anorexia. So that happens, it's called anorexia purging subtype, which is probably more detailed than you need. So some considerations. Bariatric binging can look very different. Now, of course, I've had patients over the years that could binge, kind of full on, a very large volume of food. But for the most part, you have to think about what is normal for a bariatric patient to consume and what period of time. And if it's, over that, that's going to be considered a binge. And it also has to be accompanied by that loss of control. So for example, if last night I ate 3 pieces of pizza for dinner, maybe that wasn't the healthiest choice, but it's not necessarily going to be considered a binge for me. But for a bariatric patient, that very well might be a binge. And then the vomiting is specifically with the intention to compensate either for consumed calories or to help in their mind control their weight. And so really looking at the intention behind it, because post-operatively, we know patients do vomit, they say food got stuck or they were trying to unplug. And so we have to look, if somebody is saying they're vomiting frequently, look at kind of the whole picture. And then I know Erin's talking about B1 deficiency. So that is definitely something to be on the lookout with these patients and assessing with their labs. So binge eating disorder is actually the most common eating disorder, both pre and post-operatively. So this is, about 50% of lifetime prevalence in MBS patients. And individuals will feel a loss of control over how much they're eating, followed by a lot of guilt and distress. There's so much secrecy and shame involved in binge eating disorder, a lot of isolation and sneaking and hiding. And so it's usually a large amount of food within a short period of time. Again, you have to look at the considerations for what's a large amount for a bariatric patient. It's got to be occurring regularly and meet 3 or more of the other criteria. So The considerations, like I said, it's most common. I haven't ever seen full-blown binge eating disorder post-op that wasn't a relapse of pre-op. So it's not something that usually newly occurs after surgery. It's most typically a recurrence of disordered eating from previous history. And I see it, and research supports that it's most likely to occur 18 to 24 months out. So kind of after that honeymoon phase is over in patients. And, you know, as they're able to eat more food and hunger returns, you know, you might see some resumption of binge eating. I've already talked about Gray's binging, where it's that, again, kind of picking and nibbling all day long. And another thing to really be aware of is that sometimes patients binge via caloric beverages. I have definitely seen this. I had a client who, you know, was kind of the trifecta of the Starbucks drinks that are almost like milkshakes, sweet tea, soda all day long, continuously throughout the day, to where she was getting, you know, thousands of calories in through drinking beverages. And she did see it as a binge and said it's just easier to do than eating food. So, you know, previous to surgery, she was, you know, would binge more on food. After surgery, it changed to caloric beverages. So that's something to be aware of. Is it just like, okay, they're being, you know, non-adherent to the nutrition guidelines and having, you know, a sweet beverage every now and then, versus someone who's, you know, compulsively consuming them. And this is, you know, binge eating disorder is definitely frequently associated with weight recurrence. So if we've got patients coming back to us with weight recurrence, really doing a full assessment. I know I've been to lots of talks recently on anti-obesity medications, which I think can be a great adjunct, but not being so quick to prescribe them if there's weight recurrence, if you haven't looked at the whole picture, because if there's an untreated eating disorder, we definitely want to address that. So the course of treatment, I know this can look like an overwhelming slide, like, oh my gosh, how can anyone do all of this? And this is individualized. So not every patient is going to do all of these things, but most definitely any patient with an eating disorder needs to have a full medical evaluation, labs, EKG, and kind of follow up as necessary, especially if things are abnormal. And then definitely individual therapy and nutritional counseling. So, you know, we have to stay in our lanes, and I know a lot about bariatric nutrition, having done this for a long time, but I still need to have my RD counterparts doing the nutrition piece of things and helping rehabilitate these clients nutritionally. Also, if there is comorbid mental health issues, psychiatric care can be a really important piece of the puzzle. I'm going to highlight food records. This is something that we do with our eating disorder patients, where more so than like MyFitnessPal that does macronutrients and, you know, calorie counting, we use food records that are looking more at just self-monitoring their food intake and the thoughts and the feelings. So we use Recovery Record, which was created for eating disorder patients, but has a bariatric component to it. So if the patient is a bariatric patient, they would use that part of the app along with the, you know, eating disorder piece of things. And so again, that's where they're not seeing as much in terms of tracking numbers. Same thing with weighing. We, you know, people can get really obsessive about their weight with eating disorder. So we weigh our patients blindly. You know, they step on the scale backwards. Doesn't mean we don't give them any feedback at all. But again, you don't want them to get so obsessed about the number. And depending on the severity of the eating disorder, you may need to refer them to a higher level of care. Now, there are guidelines for this. I've put them in the references. This is, you know, the different levels of care, kind of from least invasive to most, you know, residential and inpatient. Someone's going to have ongoing, or not ongoing, 24-hour monitoring and support. And, you know, in an inpatient setting, if somebody's medically compromised, they're going to be able to take care of them there. You don't have to know what your patient needs. If you're going to refer someone, they would have an intake assessment with someone at a treatment center that would be able to recommend, based on their presentation, what is the most appropriate level of care. So I'm going to real briefly highlight just a few treatment strategies. Had to cut down a 40-minute talk to 15. So I left the slides in because I know people will want to know some of these. but I'm just going to highlight a few things on each. So for anorexia and atypical anorexia, I really should have put nutritional rehabilitation and weight restoration or stabilization at the top. And it can be hard to kind of figure out where that person needs to land. So that's really where the dietitian comes in, is helping them with a meal plan to get on track in a bariatric way, but also, where they're getting their nutritional status back up to where they need to be. Very common to have concurrent conditions. In all my years of treating eating disorders, I've never seen someone who just had an eating disorder. So I'm treating eating disorders and anxiety, eating disorders and trauma, eating disorders, OCD. So definitely important to assess the concurrent mental health conditions and treat those. For bulimia, where it's really initially very behavioral, we're breaking that binge purge cycle by identifying and responding to triggers, creating alternative coping, delaying and distracting, working on impulse control. And again, the concurrent conditions, research shows with bulimia, most common are personality pathology and untreated trauma. Trauma in about 90 to 95% of patients with bulimia. And then for BED, again, looking at the triggers and responding to them, finding different ways to self-soothe. This can be really tricky in someone who's spent their whole life using food as a coping mechanism. So really learning, have to relearn a whole new way of dealing with things. Breaking that addictive cycle, they may need pharmacological intervention. Again, not my lane. We do have a psychiatric prescriber. She prescribes a lot of naltrexone, which has empirical support for treatment of binge eating and tends to have some of the less side effects than some of the other things. I don't love stimulants being used unless someone has concurrent ADHD. And the great resource on here is the Food Addiction Recovery Workbook. I've used that both individually and in group with clients, and very positive response to that. So takeaway messages: we got to recognize and treat eating disorders in this population to help mitigate complications and encourage long-term success. Sometimes we're going to see a patient present for the treatment of an eating disorder for the very first time after they experience some type of postoperative complication, but they may have had an eating disorder for years prior and it just was missed. Definitely weight is not an indicator of the eating disorder, looking at the behaviors. And so as bariatric specialists, the more competent we are to treat eating disorders, the better quality care we provide. So I have my contact information on my slides, and I don't know if these are going to be available to folks, and the references. So that's my story.
Awesome. Kelly, that was such a great presentation. And we already have a question in the chat box, but I'm going to go ahead and let everyone present, and then we'll do questions at the end. So as you're thinking of questions, just go ahead and write them down in the chat box, and we'll make sure to cover those. So great information, and thank you. Next, I'd like to introduce Erin Thompson, and Erin is going to speak to us today about B1 deficiency. And, actually, Erin did a great presentation for our weight management DPG, I think it was last week or the week before, and she had presented the same thing at the conference. So it's a really great topic on B1, and I think that it's something we could all, value to hear as dietitians and healthcare providers for sure. So let me tell you a little bit about Erin. She's a registered dietitian with 23 years of experience with a variety of populations. So she's a certified diabetes educator, a certified nutrition support clinician, and board certified in obesity and weight management. So she's really done it all. So in the last 8 years, she's been working just significantly with bariatric patients, and she has a wide variety of presentations and that she's given over the last several years. So thank you, Erin, so much for speaking today on this very great topic, and I'll let you take it away.
Yes, I do. Yeah, you guys.
Erin, you're muted. I'm going to unmute you. I think I can do that. I think you need to unmute yourself. There you go.
Are we good now?
Perfect.
Sorry about that. So let's talk about thiamine deficiency. I have no financial disclosures to, and then we got our case study here. So the first time we met this individual, it was in 2018 for her initial consult. What was unique about this individual's past medical history, she's a 30-year-old African-American female, and she'd had 4 CVAs before pursuing surgery. And so that was kind of interesting. When we asked her, why are you interested in pursuing surgery? She wanted to have a sleeve gastrectomy because she's had multiple strokes before age 30, and it's been suggested that weight loss should be able to help with managing her high blood pressure and reduce risk of further stroke. And of course, she wants to be healthier for her family. So I have been tracking her thiamine trends over time. In 2018, we were checking thiamine 2 weeks before surgery in our pre-op visit. I actually worked with this individual for 8 months prior to surgery. Her insurance required 6, but still needed to fine-tune her habits. So we worked together for 8 months. Interesting to note, 15 to 29% of individuals with obesity seeking metabolic and bariatric surgery have existing thiamine deficiency. We've treated her per our protocols, and then 6 months later we followed up, and unfortunately she was not adhering to her vitamin regimen, and thiamine dropped to 41. So again, we went through our protocols, thiamine injection, let's take an extra 100 milligrams of thiamine, please try to be consistent with your bariatric vitamin. At 1 year post-op, she normalized. So, and taking her vitamin regimen on average 4 days a week. So I thought that was helpful information that doesn't have to be 100%, at least, 80% of something better than nothing. 2 years post-op, levels started trending down again. And we'll talk about 3 and 4 year post-op, what happened in her case. Again, not adhering to the vitamin regimen, but she had a lot going on. So main things that she complained of were paresthesia, horrible pain in her hands and feet, and brain fog, memory loss whenever her thiamine levels were low. I found a really great article from Kearns et al. Talking about thiamine deficiency in people with obesity. And there's 4 proposed mechanisms for why an individual with obesity who hasn't had surgery yet may have low thiamine. So decreased intake or absorption, poor diet quality. In this individual's case, she did not drink alcohol excessively, but she did have a diet very high in simple sugars, lots of sweetened beverages and so forth, and not enough whole grains or legumes. Increased destruction or inactivation. I live in East Texas now, and sweet tea is a religion. And it's amazing how many of our patients have thiamine deficiency who tend to consume large quantities of coffee and tea. So there's some polyphenols in it that may reduce or destroy or inactivate thiamine. I also found it interesting that raw seafood can possibly reduce thiamine levels also. So people who eat sushi shouldn't have any excessive losses. However, when we look at increased utilization, an individual who consumes a lot of carbohydrate may have a higher thiamine need. So we were wondering if maybe that was another reason why her thiamine levels tend to be low. One thing I noted that's not on this slide, I did find some research that suggested African-American individuals sometimes have a lower thiamine level as well. And whether it's genetic or if it's related to diet quality, that's the question. So I found that kind of interesting. 2022 and 2023, our patient already had surgery 4 years post-op sleeve, had significant body weight loss, some regain, but she had a 5th CVA last summer and was diagnosed with moyamoya disease. So this is a rare condition where the collateral or the carotid artery is kind of narrowed, and then there's collateral arteries that develop throughout the brain. So it gives off kind of a smoky look and on the imaging. So it turns out it was really kind of a structural issue that was causing a lot of her CVAs. So she was referred to a vascular neurosurgeon at UT Southwestern. We're about 2 hours east of Dallas. And she had a cerebral artery bypass. And incidentally, at the same time, she was experiencing extreme menorrhagia. So her ferritin levels and her hemoglobin hematocrit were really low. So she was being evaluated for an iron infusion because she'd been on long-term anticoagulation and the menorrhagia. So she actually had a hysterectomy earlier this year in January. 1 month before she visited with us, she saw the hematologist and they checked her thiamine. It was 44 because she was not adherent to her vitamin regimen during all of the issues with her brain. So they had her start 100 milligrams of thiamine. At our visit a month later, we saw that lab and we said, 100 milligrams of thiamine is not going to do it. She needs an injection. So per our protocol, we gave her 100 milligrams for 2 days in a row. And then I said, let's bump up your oral thiamine to 100 milligrams in the morning, 100 at night, per the 2016 ASMBS guidelines. Now, our surgeons for the longest time have always just given 100 milligrams of thiamine and 100 PO based on some research that they had from years ago. When we saw this article in the Bariatric Times, they kind of jumped on that. They're like, oh, that confirms what we've been doing all along, that if someone has paresthesia, mild cognitive changes, that would be appropriate. So when I presented this at ASMBS, a lot of people started taking pictures of the slide and I said, no, this is incorrect. So actually, if you look at the 2016 ASMBS guidelines, which I looked at a little closer last year, repletion dose can be 100 milligrams 2 to 3 times a day. But mainly the IM therapy was where we needed to address or really reassess. So our nursing took a little closer look at this too. And we talked to our doctor and he said, yeah, let's increase to 250 milligrams of thiamine IM anywhere from 3 to 5 days. And then reevaluate and see if we need to do monthly injections. And a side note, I always asked my patients when they had their 100 milligram thiamine injections, how do you feel? And they'd always say, about the same, no difference. So it'll be interesting to see what happens when they get 250. So we checked a month after her 100 milligram of thiamine injection, levels rose to 91. So I highly encouraged her, let's get back on your bariatric vitamin and take your 100 milligrams PO of thiamine twice a day. Followed up with her 3 months later, and unfortunately, she was not taking the bariatric vitamin. She wasn't taking her thiamine. So we rechecked. Of course, it was low. So that's where I talked with our doctor and I said, let's see if we can adjust our protocol. So we gave her the 250 milligrams of IM thiamine, which, by the way, is extremely painful. However, the results are worth it. And also, I wanted to experiment with a product called benfotiamine, which we'll talk about in a moment. So benfotiamine is a synthetic vitamin B1 that is fat soluble rather than water soluble. It was created in Japan in the late 1950s. It's a precursor that can be converted to thiamine in the tissues. And then there was some controversy about the bioavailability compared to regular thiamine. When I did a literature search for benfotiamine, there was a lot of evidence in brain diseases like Alzheimer's and Parkinson's, diabetic neuropathy and retinopathy, and alcoholism, but I was unable to find any literature in the bariatric population. So the way that I learned about benfotiamine was through our patients. So a couple of years ago, I had an individual, he came in and his levels, thiamine, whole blood thiamine levels were 1200. So one of the doctors I worked with was like, wow, let's check into this. Maybe this is something we could do for our thiamine deficiency patients. Have to backtrack too. We always check whole blood thiamine, not plasma thiamine. Per the guidelines, whole blood is more accurate. So we had a couple patients that have tried it. They noticed improvements in their neuropathy. That was the main reason they were taking it on their own volition. So that's how we learned about benfotiamine. So back in May, our patient came for her 4th of 5 injections, and she was a completely different person. Prior to her injections, she was lethargic, kind of down on life. And that 4th injection, she came in, she's like, Erin, this works. I don't care how painful it is. I will do this because I have no more pain in my hands and feet. I'm sharper, feeling like I want to walk again. And so definitely upping it to 250 milligrams definitely was worth it for this patient. And she was continuing to take the product with benfotiamine and the daily 100 milligrams of thiamine as well. So we decided let's continue this plan. We rechecked her in July and thiamine level was 136. She still feels amazing. I still see her once a month. And we decided if she gets deficiency symptoms again, then we'll definitely do another thiamine injection. So I actually saw this individual on Monday, and again, she has issues with adherence, and she's noticed she's been consistent with her 100 milligrams of thiamine daily. She mentioned to me that when she doesn't take the product that has benfotiamine in it, she doesn't feel as well. But the main reason she doesn't take it, it stinks, and as you know, thiamine tends to smell really bad. So she has to take it at night for best adherence. She was also taking 1,000 of B12, some vitamin D, and CoQ10. So we had another chat, and I said, listen, if we just tried this bariatric vitamin, we can consolidate some of your vitamins. So she's gonna try it. I gave her some samples, and then we agreed that she could maybe do the 2 capsules with the benfotiamine product. I have to mention too, this benfotiamine product that she's using, it's a souped up B complex. So she's getting her other B vitamins as well. And then let's add your calcium citrate since we're trying to fine tune. So pearls of wisdom regarding thiamine deficiency. What our practice learned is that let's check at baseline consult so we can address deficiencies prior to 2 weeks before surgery. So that's a big thing that we've addressed. And incidentally, we've had patients who ended up not having surgery, but still had low thiamine. I had a gentleman last week, actually, and he said, gosh, I've had this brain fog. And it turns out his thiamine was 43. Sometimes people with a history of diabetes can have some issues with thiamine being low also. So it really has helped some of our patients who, they go to the neurologist and can't find any issues. Turns out it was a vitamin deficiency. Revisit those 2016 ASMBS guidelines periodically and update your protocols. There's so much information in there. And every time I read it, I see something that I missed. So definitely keep up with that. Consider including family members to remind patients to take thiamine, especially if they have short-term memory loss. Maybe we just need some reinforcement. I would be interested in further research on the utility of benfotiamine products in the bariatric population for sure. And then our biggest thing, we realized that we had a little bit of weight bias. We assumed that weight loss would help improve this individual's reducing her risk for further strokes, but it turns out it was, a physical rare disease. So if a younger person's had multiple CVAs before age 30, definitely check with neurology for clearance, because it could be an underlying issue not related to weight. So I got some references for you, and that's it for thiamine.
Great presentation, Erin. Thank you so much for that. Wonderful. And again, a couple questions here in the chat box, but we will get to these in just a second. I want to go to our next speaker, Maggie Dunham. Thank you, Maggie, for speaking with us today. She's going to speak with us about marijuana and bariatric surgery. And I think that was definitely a hot topic at the conference. So a little bit about Maggie. Maggie is a nurse practitioner and a program coordinator and has been working with bariatric surgery patients since 2007. She's grown her program from initially 100 patients, and now she's completed over 6,000 surgeries. So hey, congrats to that. That's amazing. She's worked on being ahead of the curve with new standards with the latest research and related to bariatric surgery and obesity medicine. She's published peer-reviewed journals and enjoys speaking at local and national conferences on topics related to obesity. She has a special interest in decreasing obesity bias in healthcare, and she recently completed her doctorate in nursing practice with a doctoral research project related to decreasing obesity bias among nursing students. Great, I love that. All right, Maggie, I'm going to let you go ahead and take it away with your presentation. Thanks so much.
Thank you. Thanks for being asked. It's a really interesting topic of marijuana. I know it's been around for in some states legally, both recreational and medicinal purposes for a while, but there's really still very little research out there as to how it pertains to the bariatric population. So we're starting to see some good articles on some studies. And the reason that I actually embraced this title was because I was charged with creating our protocol at our office on the use of marijuana in bariatric surgery. So I have no disclosures. When we talk about marijuana, we're talking about cannabis. There's a lot of terms that are being used, THC and CBD. When I talk about cannabis, I'm talking about the THC, particularly for this lecture, and the nice colloquial marijuana. It is the most commonly used psychotropic substance after alcohol. I do intakes on our patients all the time, and I felt that I was probably in the minority because it sure felt like everybody is using some sort of marijuana product out there these days. So it is quite commonly used. It does interface with two receptors, CB1 and 2, and that makes a difference because those receptors do influence some of our practice and some of the medications that we may need to use for patients. Inhalation or smoking, most common form, and I did write down for you the absorption times. I thought that was interesting as different forms of cannabis or marijuana is absorbed. And these are all of the forms that are available to patients out there. CBD, I just wanted to throw a little bit in there because there are a lot of our patients that are using CBD for conditions related to pain, related to other issues. So I just wanted to make sure I did send a nod out to CBD. It does have a very long half-life. But there are some very good uses for it. With marijuana, sedation can be increased with the combination of other medications. Tachycardia can increase with different medications, especially mental health medications. Plasma levels are affected of different drugs, and I highlighted propofol in here. We use that a lot in different procedures that our patients may be going with, one of which, if you have patients doing endoscopies before surgery, we often use propofol for that. So we need to be mindful of the use of marijuana when we are going to co-administer some medications. There's also some interactions, especially with our anticoagulation, that we need to be aware of when a patient is in the habit of using marijuana products. Assessment starts day one. We are very used to talking about smoking and assessing a patient for their smoking habits. We should be combining that with the use of marijuana and CBD products. So that should really start at the beginning. And just like you asked for cigarette smoking, how many, how long, when did you quit? These are questions you should be asking about when we talk about marijuana also. We can really have some significant interactions with anesthetics, cardiac events, and pulmonary events after surgery. So screening is really important. Now, when you think about screening, we do tobacco screening by urine prior to surgery, just to make sure that our patients have abstained, just like we've asked them to. But it really isn't recommended when a patient has admitted to using marijuana. It just does not seem to be clinically indicated unless you think they're acutely intoxicated, which you would know by your history and physical anyway. Recreational use has also the potential to be mixed with other substances. So we need to be mindful that when a patient says that they are using marijuana, they may also be using some other substances known or unknown to themselves. Chronic use has been linked to an increase in post-op nausea and vomiting up to about 20%. So when you are doing some ERAS medications, you might want to take that into account, maybe adding in, if you don't already use an antiemetic preoperatively, using either an amend type product or a scopolamine type product. Apologize for using those trade names. The generic ones are slipping my brain right now. But patients taking those cannabinoids preoperatively may have a post-op risk when it comes to post-op nausea and vomiting, and additionally pain levels. And we'll talk about the pain interaction in a moment. Cardiac, and why we have some now policies, anesthesiology groups are coming up with some new standards as to when to stop marijuana use preoperatively is because there are some cardiac events that can occur if it's used acutely and in low doses. Often the recreational use, we may see tachycardia and hypertension, but for those that are using higher amounts or chronically using, we may see the opposite effect with bradycardia and hypotension. So we want to make sure that that patient isn't having a higher oxygen demand, more at risk for an MI, tachycardia, AFib, flutter, blocks. So it's very important to, of course, know that the patients are using, and then anticipate what might occur postoperatively. Of course, pulmonary, there are some similar effects with smoking when you smoke cigarettes or cannabis. So we do have some airway disease that could occur. Inflammation suggests that it's similar to smoking tobacco. And we really just want to discourage recreational use, just like we discourage it from cigarette smoking because of the harmful effects to the lungs. Now, does that mean that all forms are discouraged? And really, that's where your conversation and your relationship with your patient comes in. Discussing the effects of marijuana on the body should be a conversation that we have, just like we do with effects of cigarette smoke on the body or any other substances. The immediate effects of oral or inhaled THC can cause some bronchodilation, but it's funny that when you change the form, you could possibly have bronchoconstriction. So it really is important that we talk about the forms, not just the use of, because the effects can be different. Understanding the postoperative risk in our patients, some research is showing that we can have worsening pain reception and increased postoperative opioid use, and that higher levels of pain, greater use of opioids occur. And when they compare that with non-users, there is more of an effect with cannabis users. Preoperative counseling is key. It really is the crux of the matter, is just, we engage our patients from day one and we develop this trusting relationship. When in bariatrics, we are pretty much the first people that listen and understand where our patients are coming from. And a lot of our patients have multiple joint issues or, other issues that they may use marijuana to improve. So since we are developing that great relationship, building a trusting relationship so that patients feel comfortable talking to us about their marijuana use is key, because then we can really stave off a lot of complications and do a lot of education preoperatively. We know that research is starting to show that long-term frequent and infrequent users are still experiencing more post-op pain. So what do we do with that? Really think about multimodal anesthesia, regional anesthesia, using opioids as rescue. Chronic pain is one of those most common reasons people are using medical marijuana. So we have to think of alternatives, working with the team, working with pain management to really figure out what's going to work for this patient in particular preoperatively, so that we address post-op pain needs is key. Because of course we don't want the first thing that our patients do when they get home is to have, a smoked form of marijuana, which is affecting their lungs and their respiratory status. So if we can come up with a good long-term plan, we can stave that off a little bit. Anesthesia, we know that anesthesia requirements may be greater for cannabis users than non-cannabis users. Adjusting induction medications. But I say that with a big, huge asterisk, in that we really need to do more research in this entire field to understand the effects in the short and the long term in bariatric patients. We're starting to see it now, but we are on the beginning of the wave. Another thing that can happen in our patients that are cannabis users is the hypothermia, that shivering that happens maybe more pronounced postoperatively, delayed gastric emptying, decreased intestinal motility, We can also have that nausea and vomiting. We know that gastric emptying is slowed significantly. Also remembering if you're doing an endoscopy, you may need more fentanyl. We also need to look at pain scores postoperatively. Of course, we need to discourage unhealthy health habits, regardless of what they are. Smoke form of cannabis is similar to smoking tobacco, and we all know and do encourage our patients to refrain from that. What you will find in the literature is very widely, it's a very wide range of times. There's a really good article, and I think I put it first on my reference list from Shaw. It's probably the most comprehensive set of recommendations so far, and it's very recent. I believe it was published in 2023, of anesthesia protocols for cannabis users. So the most common time frame to have patients refrain from cannabis use is about 72 hours. If you have to do an acute surgery on someone and more emergent surgery, you try and at least have a 2-hour window from last use. Habitual users may need more induction medications. So kind of keeping that in mind. So we really want to make sure that we're looking at the timing. So even just single doses of single events of using THC type products make a difference. So if you have somebody that is having severe nausea and you want to try, if your facility has access, dronabinol is a synthetic THC, and that actually has been used in other patient settings, in cancer patients who have had nausea post-treatment. They've been using this synthetic form. But unfortunately, in post-op acute care, that synthetic form isn't always enough. Just a reminder that warfarin is affected by cannabis use. So you do want to make sure that you are monitoring for bleeding. Histamine agents should be avoided. Other CNS depressant agents, some SSRIs in combination with cannabis should also be monitored for effect. And people that use chronic use are more likely to be admitted. So we don't want our patients to be readmitted, right? So we need to be looking at that, nausea, vomiting, opioid requirements. Identification is absolutely key. But I want to throw, this was like just such interesting fact that cannabis users did not experience inferior weight loss after bariatric surgery. Now you would think, and I've been told this a million, well, how about when they get the munchies and they might eat more? But honestly, that doesn't seem to be the case. So they did a good study. It was a small scale study, and they looked at long-term weight loss. And they found that marijuana users actually at 3 and 5 years had a more sustained weight loss. Maybe they were happier. Maybe they coped better with stress. I'm not real sure. Like I said, these are all just interesting preliminary facts that are all just kind of jumbled out there that we have to tease out. No increase in 30-day complications. The same level of substance abuse and depression, but slightly increased in marijuana users. We really need to think about getting our patients that are chronic marijuana users into some sort of counseling for mental health, just to make sure that we are addressing that need. And just so you all know, it's there, it's here. It's research is showing that 6 to 8% of our patients are using it. And I swear it's higher in our population. And how much is full disclosure and how much are people not admitting? But at least 6 to 8% of our patients are admitting to cannabis use. So it's something we absolutely need to address. My references are all here. That is the first article here. It is the most recent recommendations, and it's a good consensus guide for the management of perioperative patients on cannabis use. So if you're going to look at anything in there, that would be one I would look at. I know that's a big rush, but I know we are constrained with time.
Wow, talk about great presentations. Thanks to all of you for this. Couple things, and gosh, I feel like we could talk another half an hour, but we have a few minutes left to let you know about slides. We're going to work on those and see if we can present those. So we will, I know everyone is very interested. Maybe we can have time for one question. This is going to go to Kelly. I have two patients, one pre-surgery male, one post-surgery female. Both have disclosed untreated eating disorders when younger. The female has a BMI of 29 or 21, recently gained weight and is panicking, is in therapy, but not for eating disorders. Has recommended to an eating disorder RD. She doesn't feel that she needs any of that at this time. Any recommendations? Part two, do we have time for part two? What are the red flags to look at when he is struggling for the male who is pre-surgery?
So, I mean, I think really just building rapport with the client to encourage follow through with recommendations and referrals. And so, I mean, most definitely if she's panicking, let's, use some motivational interviewing to get her to eating disorder dietitian. If she says, oh, I don't need that yet. It's like, okay, well, why don't you just go, at least for the intake and see how that goes. And really just trying to get their foot in the door. Because, if you tell someone what to do, they're going to be less likely to do so, but it definitely sounds like that's a warranted referral. So just working to hopefully try to make it more their idea. What would be the harm in going, and just trying it out, seeing what they have to offer.
Thank you. Rena, okay, and this is on the marijuana presentation. This was my topic too, or my question too. 3.4 times readmission, is that in the 30-day or what's the time frame?
Yes, in the 30-day readmission time frame.
Perfect. Okay, and one more question. Emily said, and this is for Erin, everybody gets a question. Do you have anything in place in the acute care settings as far as identifying, flagging patients with those symptoms coming into the ED and actually receiving thiamine as part of a treatment?
So glad you asked that. That's my PI project next month here. Stay tuned.
Great. Wonderful. Sounds great. Well, gosh, guys, thank you so much. I think we got all the questions. We will be back in touch with all of these presentations. Andrew Neek from ASMBS just posted the YouTube channel, so you can go back and rewatch any of these presentations, and we will let you know about these slides. But thank you, ladies, for this wonderful recap and great presentation. Way to spend our lunch, right?
Thank you, everyone.
Yeah, have a great afternoon. Thank you.
Thank you.